We're now moving on into the chapter, still chapter 16, the second part of the endocrine system. And we are going to start with the thyroid gland. The thyroid gland is that butterfly-shaped gland in the anterior neck on the trachea and just inferior to the larynx. It's made up of the isthmus, which is that median mass that connects the two lateral lobes. Inside it, it has a lot of follicles. These are hollow spheres of epithelial and follicular cells that produce the glycoprotein thyroglobulin. And here you go. You have right there the um, microscopic photomicrograph of the thyroid gland follicles. Now, each of these follicles, these compartments here, you call them the follicles, is filled with colloid and is lined by simple cuboidal epithelium, which you call the follicular cells. Now, the cells that are not touching the follicles are what you call the parafollicular cells, and they are the ones that are secreting calcitonin. The follicular cells would be secreting the thyroid hormone. The colloid inside it is actually the fluid of the follicle, and it contains the thyroglobulin plus iodine, and is the ones that are precursor um, to the production of T3 and T4. The parafollicular cells are the ones that produce the calcitonin. The thyroid hormone um, pretty much is this, the activity of the thyroid hormone stems all the way from the um, hypothalamus with the thyrotropin releasing hormone that is stimulating the anterior pituitary gland into producing the thyroid stimulating hormone. And the thyroid stimulating hormone react on the thyroid gland, releasing the thyroid hormones T3 and T4, which will be increasing metabolism, growth and development, and increased catecholamine effect. So the thyroid hormone is virtually, therefore, because it's a metabolic hormone, is virtually affecting every single cell in the body and therefore would have uh, receptors for every single cell in the body. And um, it triggers transcription of various metabolic genes. And the effects of thyroid hormone would include increased metabolic uh, rate and heat production, which is referred to as the calorigenic effect. It also regulates tissue growth and development that is critical for normal skeletal and nervous system development and reproductive capabilities. It maintains blood pressure. It increases the adrenergic receptors in the blood vessels. It is the body's major metabolic hormone and is found in two forms. T4, T4 has four iodine in it. It's called tetraiodothyronine. It's pretty much like it has four bound iodine atoms, and then you have also T3, which is triiodothyronine, and it has two tyrosines with one bound iodine on one end. T3 must be converted into T4 at the tissue level. Both are iodine containing amine hormones. Now, let's take a look at the synthesis of thyroid hormones inside the cell. And let me just give you a view of what this is all about. This is actually the capillary. This is your cell itself. And you can assume that it is actually the follicular cells because the follicular cells are the ones that produce the thyroid hormone. So the thyroid gland would store the hormone extracellularly in the follicle. And this is actually your follicle. In the lumen of the follicle until it is triggered by the thyroxine stimulating hormone to be released. there are 7 steps that are involved in the synthesis of the thyroid hormone. The first one, right here, you have number 1, is when the thyroglobulin is synthesized and discharged into the follicle lumen. So here it is actually like um, synthesized, and now it's actually being released into the lumen of the follicle. This is the lumen of the follicle. Then iodide is trapped. The iodide now is actually coming from the blood and is now getting inside the cell and are actively taken. They are now actively taken into the cell and is released into the lumen. A third step is that the iodide is oxidized. The electrons are removed, converting it into iodine molecule, into I2. Then iodine now is going to be attached into the tyrosine, and it is mediated by an enzyme which you call peroxidase enzyme. It can form mono monoiodotyrosine. These are the monoiodotyrosine, the MITs. You could see the tyrosine having only one iodine. And then you have diiodotyrosine or the DIT. You could see that it has 2 iodine molecules attached to one tyrosine. Now, the iodinated tyrosines would link together to form T3 and T4. And you could see that one diiodotyrosine linking to a monoiodotyrosine forming T3, or 2 diiodotyrosine linked together will form a complete thyroxine. So now the colloid itself is endocytosed. It's now going to be taken in by the follicular cells. This is your follicular cells, this entire thing here. The vesicle is now combined with the lysosome. Okay, there you go. It's combined with the lysosome. And eventually the lysosomal enzymes would cleave the T3 and T4 from the thyroglobulin. You could see that it's actually being cleaved, and it's now going to be released. It will now be diffusing into from the cell cytosol into the capillary outside and into the capillary. Mostly T4 are secreted, but T3 is also secreted. T4 must be converted into the T3 to the tissue level because T3 is more preferably the one that's going to be used by in the metabolic activity, in enhancing the metabolic activity, because it is because it's a better form. Okay, and then you have already the transport and regulation where your both T3 and T4, whether they are converted or not, is now going to be transported by thyroxine binding globulins, which is your TBGs. So both will bind to the target receptors. But T3 is 10 times, just like what I said, 10 times more active because of its potency than T4. Therefore, in the peripheral tissues, enzymes need to convert T4 into T3. Okay, or else it's going to be a little bit slower. T4 is slower, T3 is more potent, so they had to convert T4 into T3. The regulation of thyroid secretion, we did this already in part A of the endocrine chapter. And I am just going to just give you a little bit of a review just to pretty much like a um, jiggle your memory. Okay, so this is actually about the transport and regulation. This is where the hypothalamus will release the thyroxine releasing hormone to the anterior pituitary. The anterior pituitary has specialized cells that produce um, the TSH, or the thyroxine stimulating hormone. And the name of those specialized cells are the thyrotropes. So the the anterior pituitary thyrotropes are now going to be stimulated by the thyroxine releasing hormone from the hypothalamus. Upon stimulation, the thyroxine stimulating hormone is now going to be released in the bloodstream. It will now be picked up by the thyroid gland, and the thyroid gland are now going to be stimulated to produce the thyroid hormone, the T3 and the T4. And then it's going to be acting on the target cells. One, once it is actually circulating around, there's going to be like the feel that there's actually too much or too many or of the these metabolic hormones, and therefore we don't need too much, too many of them. We just need the right amount of hormones to stimulate metabolism in our cells. Too much of it is not good. So, in order to avoid the flooding of T3s and T4s and increasing the metabolism of the cells too much, way beyond our capacity, then there's actually a negative feedback. Once a level of hormone has been reached, then this particular level of hormone is going to be the negative feedback that would inhibit the anterior pituitary and the hypothalamus from further producing the hormones that would stimulate the production of TSH. And here you have, as usual, a table that's going to help you review the major effects of the thyroid hormone, the T3 and T4 in the body. So let's take a look at some homeostatic mechanisms, some disorders of the thyroid gland. Okay. Hyposecretion of thyroid hormone in adults can lead to what you call myxedemia. The symptoms will include low metabolic rate, very thick or dry skin, puffy eyes, feeling chilled, constipation, edema, mental sluggishness, and lethargy. If due to a lack of iodine, goiter, such as the one in the picture right here, may develop. Lack of iodine increases the thyroxine hormone level, which triggers an increase in the TSH secretion, triggering the thyroid to synthesize more and more unusable thyroglobulin, and therefore the thyroid will enlarge. So the thyroid hormone is really critical for the normal growth and brain development, even and most especially in childhood. Congenital hypothyroidism is usually caused by poor development of thyroid gland. The pituitary, there will be pituitary problems or certain pituitary problems or maternal medications may sometimes contribute or would sometimes rarely affect a baby's ability to make the thyroid hormone. This may be asymptomatic, okay, or present with weak cry or poor feeding, constipation, or prolonged jaundice. But actually, this is already a disorder. And thyroid hormone replacement is very crucial here and usually needs to happen for the rest of the life of the individual or the baby itself. Then you have your hypersecretion. When you have hypersecretion of the thyroid hormone, the most common type that we have is actually what we call Graves' disease. Graves' disease is an autoimmune disease. It makes the body makes abnormal antibodies directed against the thyroid follicular cells, and these antibodies mimic the thyroxine stimulating hormone. Thus, it is stimulating the thyroxine hormone release. And one of the symptoms is actually this lady right here with exophthalmos because of her Graves' disease. The symptoms would include elevated metabolic rate, sweating, rapid and irregular heartbeat, nervousness, weight loss despite adequate food. And exophthalmos or bulging of the eyes is pretty much become a common symptom of people with Graves' disease that cannot be controlled. Treatment would include surgical removal of the thyroid or radioactive iodine to destroy the active thyroid cells. Now let's go to the next hormone that is actually produced by the thyroid gland, which is your calcitonin. Calcitonin is produced by the parafollicular cells, the neighboring cells of the follicular cells in the thyroid gland. This is produced by the parafollicular cells in response to high calcium level. This is antagonistic to the parathyroid hormone. There's no known physiological role in humans at normal physiological level, but at higher than normal doses, your calcitonin will inhibit osteoclast activity and prevents the release of calcium from the bone matrix. And it stimulates calcium uptake and incorporation into the bone matrix. And here you go, right at the back or posterior to the fleshy thyroid gland, you have button-like parathyroid glands. And the there's just about 4 to about 8 tiny yellowish brown gland that is embedded in the posterior wall of the thyroid. It contains many cells, but two types of cells. They have the oxyphil. The function of the oxyphils are, these are your oxyphils. They are not really clear, and the parathyroid cells that secrete the parathyroid hormone, or otherwise known as your parathormone or PTH. PTH is very important. It's one of the most important hormone in calcium homeostasis. It is secreted in response to low blood calcium level and is inhibited by rising levels of calcium ions. The target organs would be your skeleton itself, the bones, the kidneys, and the intestine. The function, okay, the function of the parathyroid hormone will be to stimulate the osteoclast. And if you remember what the osteoclast is from your AMP1, the osteoclast is actually the bone resorbing uh, bone resorbing cell of the bone itself. It is the one that digests the bone matrix. And so as it is digesting the bone matrix, all of the calcium that is byproduct of digesting the matrix is now going to be released into the blood, thus increasing the blood calcium level. So it enhances the reabsorption of calcium and secretion of phosphates by the kidneys. It promotes the activation of vitamin D by the kidneys, which leads to increased absorption of calcium by the intestinal mucosa. So let's take a look at the effects of parathyroid hormone on the bones and the kidneys and the intestine. So the parathyroid hormone increases blood calcium levels by promoting the release of calcium from the osteoclastic activity. When the osteoclast activity will be digesting the bone matrix itself, it releases a lot of calcium ions. So in the bone, the parathyroid stimulates bone breakdown and the resorption to release calcium and phosphate. In the kidneys, it increases calcium retention and decreases phosphate retention, leading to more phosphate excretion in the urine. In the intestine, and I'm hoping you are following this from here, okay? What the parathyroid hormone is actually doing. Uh, in the bone, it increases osteoclastic activity. Therefore, there's an increase or a release of calcium ion and phosphate ion into the blood. Okay, in the kidney, it's actually an increase in calcium reabsorption in the tubules, and in again in the kidneys, the activation of vitamin D to its active form, the calcitriol. And once it's been converted into calcitriol, there's going to be an increased absorption from the food also in the small intestine. Eventually, that's going to all of them will eventually lead to an increase of calcium ion in the blood. There you go. Okay. Let's move on into another vital organ with several hormones in it, and that is the adrenal gland. And do you remember where the adrenal gland is located? From AMP1, when you're looking at the general views of all the organs in the body, and I know this is the beginning of AMP1, you might have just forgotten it. The adrenal gland is a cap of the kidney. So it is located on top of the kidney. And too bad these kidneys here do not show any cap, but there's your cap right there. It's an enlarged version of the adrenal gland. This is the superior surface of the kidney, and you could see it from this um, picture here. You have two kidneys, and on top of it is actually the adrenal gland, which serves as like sort of a cap. And the adrenal gland is paired because each kidney has one adrenal gland on its top. It's pyramid shaped, sitting on top of each kidney, and is referred to as the suprarenal gland, structurally and functionally because of its location. Now, if you're going to cut the mass or the adrenal gland itself, you find out that the outer portion of the entire gland, which you call the cortex, will be made up of several different types of cells that would carry different uh, adrenocorticotropic hormone. You call them adrenocorticotropic hormone because they're secreted in the adrenal gland in the cortex of the adrenal gland. So this group here, or this particular part here, is a cortex, or the outer portion of the adrenal gland, and the middle portion of the adrenal gland is called the medulla. And the medulla is a nervous tissue. It has specialized cells, which you call chromaffin cells, that is part of the sympathetic nervous system. And it is also adrenal in nature and neuroendocrine in itself, because it is actually a combination of the nervous system that is producing a hormone. The hormone epinephrine and norepinephrine is produced right there in the adrenal medulla. So let's project our, um, let's now go to an interesting point right here. You have a small piece of the cortex of the adrenal gland that's been enlarged right here. And as you see this enlarged version right here, you could see that this is a diagram, it is a drawing, and therefore it presents itself really very beautifully, and you could easily relate to the differences between the layers. But in a real microscopic histology or histological presentation, it is really going to be hard, and you will have to really look at it several times in order for you to really realize the differences in the way the cells are um, the the way the cells are arranged in order to appreciate uh, the differences in the layers. So in the first layer right here, where all the cells are actually arranged in a circular manner, that's how I would see it. They call it the zona glomerulosa. Then right here, like going medial, going towards the medulla, this is actually the cortex of the adrenal gland, and this is the medullary region or the middle part. Going towards the medulla, you have the zona fasciculata. Here, the cells are arranged to me in my imagination when I look at it under the microscope. The cells here look like soldiers, and they are actually marching up and down and up and down like a radiating line, perfect line of soldiers. If you're going to look at it, this drawing is not pretty much like what it is when you look at it in the microscope, but believe me, in the microscope, you will see them really like arranged like soldiers going up and down. And you will see it when you look at all of the different um, zona fasciculata cortical cells. Then the third layer is called the zona reticularis. And just like the zona glomerulosa, the zona reticularis is um, arranged in a circular manner, clump up together, and they are darker. They have darker staining cells. And then immediately after that, in the middle, we're already in the middle of the medulla. This is now the medulla of your adrenal gland. Now, each of these layers has different hormones that are actually being secreted. And of course, the cover of the adrenal medulla is called the capsule. Make sure that you know that because you might be asked on what the cover is of the adrenal medulla when you're doing your exam. So, your adrenal cortex, pretty much this area of the adrenal gland, um, produces over 24 different hormones collectively called the corticosteroids. The steroid hormones are not stored in the cells. The rate of release depends on the rate of synthesis. The three layers of cortical cells produce the different corticosteroids. And these will be, just like what I mentioned, the zona glomerulosa, which produces mineralocorticoids, the zona fasciculata produces glucocorticoids, and your zona reticularis will be are the ones that produces the gonadocorticoids. Let's look at them with their diagram so we will understand them better. Here is your cortex. This is actually the cortex. This is a drawing of the histology of the adrenal cortex and a portion of the adrenal medulla, which is actually right on this section already. Okay, but this one here, take a look at the difference between this one and this one. This one here is the photomicrograph of the histology itself. And just like what I told you, your zona glomerulosa right here, the one that secretes the aldosterones, the cells are actually arranged in a globular manner. Then the zona fasciculata, the cells are arranged like soldiers. They're actually going up and down motion, and they are. If you're going to see the entire cortex itself, it would look like there's actually radiating cells, and that's actually the zona fasciculata, and they produce the cortisols. And then finally, you have your zona reticularis. This is actually a little bit different in color, darker staining cells, but also arranged in a globular manner. They are the ones that produces the androgenic hormones. And finally, the adrenal medulla. This is actually where the epinephrine and norepinephrine is produced. So let's look at the first one right there on top so we can single-handedly um, look at and discuss the hormones that are being produced by each of the layers. The layer here is a zona glomerulosa. It secretes the mineralocorticoid aldosterone. And you are already familiar with the aldosterone because we've been discussing them since we got into the blood vessels, since we moved into also the in the kidneys just last week, and therefore you know this to be part of those renin-angiotensin system that is regulating the reabsorption of kidneys by the reabsorption of sodium by the kidneys. So this is actually the one that regulates just to review the ones that regulate the electrolyte concentration, primarily the sodium and the potassium ion in the extracellular fluid. And these influences blood volume, blood pressure, and the level of other ions. And aldosterone is very important because it is the most potent of all the mineralocorticoids. It stimulates sodium reabsorption by the kidneys, and results in increased blood volume and blood pressure. It stimulates potassium elimination by the kidneys. And here is actually a major mechanism. This is something that you have seen already when we were doing the renin-angiotensin system in the kidney, but pretty much uh, if you can recall the regulations of the aldosterone release right when we started it in the kidney, this is pretty much it. There's no change. You have here the first one, your renin-angiotensin aldosterone mechanism. This is where a decrease in blood pressure will stimulate the special cells in the kidneys. These cells would release renin and cleaves off part of the plasma protein, uh, angiotensinogen, that triggers the enzyme cascade, resulting in the conversion of angiotensin to angiotensin 1 to angiotensin 2. So now that you have angiotensin 2 right here, it's a potent stimulator of aldosterone release. So key here is all of them is supposed to be part of controlling aldosterone release. So here, the renin-angiotensin system, one of the products here is the increase in aldosterone. Then you have also the plasma concentration of potassium. Plasma concentration, an increase in potassium level directly influences the zona glomerulosa cells to release aldosterone. And increased potassium directly stimulates aldosterone release, and low levels would inhibit this too. Then the ACTH, the adrenocorticotropic hormone, which is pretty much like released when we are under stress or in periods of increased stress. Okay, this would also lead into the release of aldosterone. Then you have your hormone that is secreted by the ventricles in the atrium of the heart, not ventricles, but the atrium of the heart. Pretty much as a result of increase in blood pressure or blood volume, it will be releasing what you call the atrial natriuretic peptide. The effect of this AMP, though, is not to stimulate the release of aldosterone. It's going to be to inhibit the release of aldosterone. So these are regulatory. Three of them stimulates the aldosterone to be released. One of them will inhibit its release. And they're all targeting the aldosterone that's being released by the cortical cells of the adrenal gland. And pretty much when aldosterone is high or is actually released, it will stimulate the absorption of sodium and water and increase potassium excretion. That eventually will result in an increase in blood volume and also an increase in blood pressure. But the atrial natriuretic peptide, because it has an inhibitory effect to aldosterone, is not going to increase blood pressure and blood volume. The effect of the AMP will be the opposite of the aldosterone because it's supposed to inhibit aldosterone. AMP is going to decrease blood volume and blood pressure. Let's go to the next layer of a cortex, which is the zona fasciculata. Right here in the drawing, they made it clearer now that the cells are actually going like, soldiers lined up and down. And when you have a full cortex that all like that, they would look like really beautifully radiating. So the zona fasciculata secretes glucocorticoids which inf- which influence metabolism of most cells and help us resist stressors and keep blood glucose level relatively constant. They maintain blood pressure by increasing action of vasoconstrictors. The glucocorticoid hormones would include the hydrocortisone, which is the cortisol itself, And this is the only glucocorticoid that is produced in significant amounts in humans. Then you have also cortisone and the corticosterone. So how is your cortisol released? Well, again, this is just going to be a review of what we have discussed already in the part one. From the hypothalamus, your hypothalamus will sense the amount of cortisol concentration in the blood. Then, under a sense of maybe stress, okay, would release the cortico, corti, cortisol releasing hormone, and is regulated by via a negative feedback loop. Then it is actually directed to the pituitary gland, anterior pituitary cells, the corticotroph, and it is now going to be producing, or it's now going to stimulate the release of ACTH. When ACTH is around, ACTH targets the adrenal gland, and it drives the adrenal gland to release or to secrete cortisol itself. When cortisol is secreted into the bloodstream, right there, it is now going to have the effect that it should be. So cortisol secretion cycles are governed by a pattern of eating and activity, body activities. Acute stress, infection, physical or emotional trauma would interrupt cortisol rhythm. The central nervous system can override cortisol inhibition of ACTH and CRH, leading to more cortisol secretions. So more on cortisol. Pretty much cortisol level would increase an increase in cortisol level would increase would result in an increase in blood sugar. It would also be resulting to a suppression of the immune system. Cortisol also would heighten memory and attention, and can also result in decreased sensitivity to pain. And it increases also blood pressure and would also decrease serotonin. So in the stress response, cortisol is released pretty much in order for the body to cope with the challenging situations that it will face under stress. It increases the blood sugar because we need the energy, we need the ATP, and we get the ATP from sugar itself. And pretty much it increases also metabolism to provide energy and alertness. And it also pretty much like modulates our immune system. And cortisol suppresses the immune system to prevent excessive inflammation and other autoimmune reactions that are brought about by too much of the white blood cells around. So the metabolic control of cortisol helps in regulating blood sugar levels by promoting glucose production and storage also in the liver. It also influences fat metabolism, increasing fat breakdown during stress. In the skin, cortisol is used topically in creams and ointments to treat inflammation, itching, redness caused by skin conditions like eczema and psoriasis. Excessive levels of glucocorticoids, though, would depress cartilage and bone formation. It will inhibit inflammation by decreasing the release of inflammatory chemicals, and it will depress immune system. There's going to be a disruption in the normal cardiovascular, neural, and gastrointestinal function. Glucocorticoid drugs can control symptoms of many inflammatory diseases, such as arthritis and allergies, but can also cause a lot of undesirable side effects. So prolonged hydrocortisone or cortisol uh, um, use is not really good. It is not really good. So here's actually some of the uh, homeostatic imbalances and glucocorticoids. One of them is actually the excess glucocorticoid, and pretty much results hypersecretion results in Cushing syndrome. It this particular disorder depresses cartilage and bone formation, and immune system is also inhibited. Inflammation. It also inhibits inflammation, disrupts neural, cardiovascular, and gastrointestinal function. And the causes of excessive glucocorticoid release will be most of the time a tumor in the adrenal cortex or overuse of corticosteroids. Pretty much, this is actually what you call the Cushingoid signs, the moon facing or the buffalo hump right there, the formation of that hump right there. So the treatment of this will be removal of tumor in the, if there's a tumor uh, in the adrenal gland, or discontinuation of the drug if you're taking too much of the hydrocortisone. You can actually take something else. Now, the reverse of this is actually hyposecretion, which we have discussed already, the Addison's disease, and usually results or involves deficits in the glucocorticoids and mineralocorticoids. Therefore, it can lead to decrease in plasma glucose and sodium levels, weight loss, severe dehydration, hypotension, and a common treatment for this will be corticosteroid therapy, pretty much. Okay, then we're getting into the bottom layer, which you call the zona reticularis of the adrenal cortex. This is the one that is responsible for producing the gonadocorticoids or the androgenic sex hormone. These androgenic sex hormones are weak male sex hormones that are converted to testosterone in the tissue cells. Some of them are converted to estrogen. For example, your androstenedione and dihydroepiandrosterone. Very much these are actually coming from the androgens in the adrenal gland. And this may contribute to, for instance, during the onset of puberty, the appearance of secondary sexual characteristic, pretty much even before puberty. Or this is actually, well, this is really true. The only source of pretty much a stimulus of the sex drive in women after menopause is actually uh, the secretion of the zona reticularis androgenic hormone. And it is also the source of estrogen in postmenopausal women because this androgenic hormone can actually be converted uh, into estrogen. Then we are now in the middle of the adrenal gland, and right there, smack in the middle. This part here is the adrenal medulla. The adrenal medulla has specialized cells, which you call the chromaffin cells, and they synthesize catecholamines. 80% of their secretion is epinephrine, and then 20% is norepinephrine. And these catecholamines usually will result in vasoconstriction, increase in heart rate, increase in blood glucose level, and blood being diverted to the brain, so it increases alertness. And then it also gets diverted to the heart, so your heart rate beats faster. And your skeletal muscle will have more blood in it, and therefore you get to be stronger. This is the epinephrine and norepinephrine is actually your fight, fright, flight response. Okay, this is on the sympathetic nervous system um, hormones that is going to be stimulated when the adrenal medulla chromaffin cells are stimulated to produce their secretions. And here you have the adrenal gland hormones in a summary in a table, which you can use to pretty much like during your to pretty much write review for the next exam. So let's take a look now at the pineal gland or the pineal gland. Pineal gland is a small gland hanging from the roof of the third ventricle. It is produced, it's actually made up of the cells which we call the pinealocytes, and they secrete melatonin that is derived from serotonin. Melatonin may affect the timing of sexual maturation and puberty. It is also responsible for our circadian rhythm, meaning our day and night cycle. When it is nighttime and there's no light, we sleep. There's enough melatonin, makes us fall asleep. And then when it's daylight, the sun is actually inhibiting. Uh, there's actually like light-induced activation of what you call the suprachiasmatic nucleus, which prevents the production of melatonin by the pineal gland. And that's why when melatonin is not going to be produced so much during the daytime, then we are awake. Okay, and the production of antioxidant and detoxification molecules in the cells is also another effect of melatonin. So let's move on to the other endocrine glands and take a look at some of the secretions of the other endocrine glands. Okay, this is actually not just other. I say this is actually one of the major endocrine glands, which is actually the pancreatic islets. You may find it really small because they are only islands in a large pancreas, but these small number isles or islet cells actually is the one responsible for our sugar, blood glucose regulation. The pancreatic islet has four major cells. Actually, two major cells, and the other two are actually like paracrines. So first you have the alpha. The alpha cells produce glucagon. The beta cells produce insulin. Now, the acinar cells, these are the acinar cells of the pancreas, is not endocrine in nature. They're exocrine in nature. They produce enzyme-rich juice for digestion. Meanwhile, your pancreatic islets would contain those alpha and beta cells, which is uh, responsible for glucose regulation. For instance, your alpha cells, they produce glucagon, which is hyperglycemic. It is a super hyperglycemic, meaning it increases sugar level. Meanwhile, your beta cells is actually the one that produces insulin, which is a hypoglycemic hormone. This is the one that reduces sugar in the blood. It makes sure that the sugar is going to be brought to the cells where it is actually needed for ATP production. So let's take a look at the differences between the two. Again, glucagon is extremely potent. There you go. Where is glucagon right here? Glucagon right there is extremely potent. It promotes glucose synthesis via glucogenolysis or glycogenolysis and gluconeogenesis. So glucose here is going to be released in the bloodstream. So it elevates, glucagon elevates the blood glucose level in times where we are very hungry and we are starving and our blood glucose is very low, the glucagon is actually the one that breaks down the glycogen in the liver or stimulates the breakdown of glycogen in the liver so that we are going to have enough glucose in the blood to so that we're not going to be hungry. So we need the blood glucose in the blood to be maintained at specific level, not because we do not want to get hungry, but because this blood glucose level is actually the level that is needed for some of the sugars to be delivered to the cells. The cells are the ones that are needing this. The cells are the ones that are supposedly converting glucose into ATP. So for the cells to produce ATP so that there will be continuous metabolism, it will need sugar. Sugar is equal to production of more ATP, and more ATP means we are going to continue our life and we are going to continue the metabolism of the cell. If ATP is not there, then the cell will stop metabolizing and it will die. And if a lot of cells will die, it will affect the organs will die, and eventually we can die if it's not going to be. So your glucagon is really very important. But in the same token, also we know that if we are eating a lot and there's really a lot of sugar in the bloodstream, the sugar in the bloodstream cannot stay just in the bloodstream. It has to go to the cells so that you can burn it and convert it into glucose. And insulin is the one that helps promote glycogen genesis, which means if there's a lot of glucose, insulin will stimulate the production of glycogen. So all of the glucose are now going to be strung together, put together. Okay, this is an anabolic reaction and produce more glycogen. It is also the one that is responsible for glycolysis. It inhibits glycogenolysis and ketogenesis. Okay, let's take a look at insulin and glucagon, or how they're actually interacting and how they are helping regulate the blood glucose level. Let's say there's an imbalance. Okay, the blood glucose level is supposed to be what? 90 to 100 milligrams per ml. Let's say that there is an imbalance, and the imbalance is that the stimulus is actually now your blood glucose level goes up. You ate too much, the blood glucose level went up. Okay, so it's going to stimulate the pancreas to release insulin. The insulin now is going to stimulate glycogen formation. So all of those glucose that is in the blood is now going to be stored in the liver as glycogen. Or some of them, insulin will pretty much like bring them over to be uptaken by the cells. Then, because now you don't have that much anymore glucose in the blood glucose level falls back to normal. So, what happens if blood glucose is actually too low? If blood glucose is too low and you are feeling hungry, very much, your pancreas, the islets of Langerhans in the pancreas, the alpha cells, will now pretty much like release glucagon, which stimulates glycogen breakdown. The glycogen in the liver, when it gets broken down, will release thousands of glucose molecules, and then the blood glucose rises back to the normal range. Okay, so here is actually another table, pretty much, which shows us the consequences of insulin deficit in diabetes mellitus. Pretty much, diabetes mellitus can be due to hyposecretion of type 1, uh, of type 1 hypoactivity of insulin, or but hyposecretion of insulin. When there's actually hyposecretion of insulin, you call that type 1. When it is actually hypoactivity of insulin itself, you call that type 2. Okay, so uh, whichever way you put it, it's still diabetes. Okay, whether it's type 1 or type 2, your insulin is actually not working, but type 1 pretty much is an autoimmune disorder. Type 2, which is supposedly sluggishness of insulin comes in um, under like after several years, upon old age. There are three cardinal signs of diabetes mellitus. First, you have polyuria, huge amount of urine output, which is actually right here. Huge amount of urine output because glucose acts as an osmotic diuretic. Okay, so here pretty much, okay, you have glucose in the blood, increased glucose in the blood, whatever it's coming from all the tissues, from the food that you're taking in, or from the liver it is. Yeah, the increased blood glucose will cause hyperglycemia, and that will pretty much like be reflected in the presence of sugar in the urine, which is glycosuria. Glucose pulls the water into the kidney tubules, and so that will promote urination. So you're going to have increased urine output, and that will also result in uh, polydipsia, polydipsia, which is excessive thirst due to water loss of polyuria. And eventually, what's going to happen is also polyphagia. Polyphagia is an increase in appetite. There's because of um, which is because of the increased muscle breakdown in the protein and adipocytes breakdown, then your appetite will also increase. Uh, you would need to be your it results into food consumption because the cells cannot they're actually going hungry and they cannot take up glucose and are actually starving. When sugar cannot be used as fuel, as in the diabetes mellitus, fats are used, causing lipidemia. And the when the fats are used and they're actually broken down, the increase in fatty acid metabolism will result in the formation of ketones, the ketone bodies. And therefore, you will have ketones in the urine, which is ketonuria. The ketones pull the cations into the kidney tubules. Therefore, you're going to have increased loss of sodium ion and potassium ion and hydrogen ion in the urine. And pretty much this is actually what you call, it can cause ketoacidosis. Or, and if you are going to leave ketoacidosis untreated, it can cause hyperapnea, or it can disrupt uh, heart activity and oxygen transport, and severe depression of the central nervous system, and eventually even coma. Okay, the ketones in hyper what do you call it, uh, ketone bodies in the urine actually will give a diabetic what you call ketone breath, or even the smell of the urine is like it has acetone on it. So the next one, the next slide, I am going to leave this to you because most of this we have already taken up when we actually did the other um, the other organ systems. Okay, so I would like you to understand that these are all going to be part of your exam. I have listed them all out here and their action and their location. And most of this we have already taken up when we took the kidneys, the heart, etc. Okay, so your discussion on the hormones also of the gonads and the placenta will be discussed in the next chapters on the reproductive system, which is probably next week already. All right. So that's it, guys.